So the first question was, which method is followed to assess the breathing pattern of a child suffering from dental or medical emergency? What answer have you written? Yes, it is listen, look and feel technique. First, you will listen to the breath sounds, feel the breathing pattern of the child. Also, look at the movement of the chest. Hmm? The most preferred mouth guards are. First, tell me what are the different types of mouth guards. What is the material used? Do you know? See, there are basically three types of mouth guards. Type 1 is stock mouth guard, which is available over the counter in the medical shops. So, what stock mouth guards are, that they are not custom made. They are not custom made for each and every person according to the impression. They are from the average impression, from the average dimensions, they have prepared the mouth guards, and so it will not fit perfectly to your dentition, but it will give some amount of protection. Okay, and the material used is PVA, polyvinyl acrylate. And type 2 is boil and bite mouth guard. Boil and bite is also same material. It is put in boiling water or hot water so that the material becomes soft and you can adapt it around the dentition, and so it is not completely custom made. It is you do not make an impression of the patient, but it is not as haphazard as stock mouth guard also. It is somewhere in between. So that is boil and bite. And type 3 is custom made, where you make proper impressions, make proper casts, and then there are biostar machines available for fabrication of night guards or mouth guards. In those biostar machines, they are either vacuum processed or heat processed. In those machines, what you do is you heat the PVA sheet, PVA polyvinyl acrylate sheet. You heat that. When it softens, it sags. um, the materials is somewhere something like this. In between there will be a disc or a platform on which you will keep the sheet, PVA sheet. Beneath that will be the you will keep the cast of the patient. So when you apply heat and the sheet gets softened, it sags a little bit. So when it sags for 1 centimeter, you know that it is perfectly adaptable and it has become soft. So you then adapt it onto the cast which is placed beneath the sheet. You adapt it onto the cast, and with the help of vacuum, it will get fitted properly on the cast, and then you remove it and you trim it according to the dimensions which are, it should cover in the maxilla, it should be 1 mm above the vestibule, and it should be away from the vestibule. It should not impinge on the mucosa. You trim it accordingly and you give it to the patient. You check for any high points, because mostly these mouth guards are used to prevent sports injuries, and night guards are used to prevent bruxism. So you will have to check whether there are any high points, because your patient is already a bruxer, and the teeth must have already gone attrition. If you give a night guard with high points, it will add to the problem of the patient. So you check all that and then you deliver it to the patient. So type 3 are custom made. And the machine's name is Biostar. What we have routinely is Biostar machine, on which we fabricate the night guard. Okay. So most preferred is type 2. Why? Because it is not as time consuming as type 1, and it is not as haphazard as type 1. Okay, it is not. It will not be poor in fitting as the stock mouth guard, but it will not be time consuming also. So most commonly used is type 2, that is boil and bite. Okay. Uh, yeah. So the second question was most preferred. So most preferred will be type 3, because it will fit properly to the patient's arch, and most commonly used will be boil and bite. Type 4 is not there. Only three types are there. So optimal, can we move on to the next MCQ? Optimal time for tooth transplantation with respect to developmental process is, yes, when the root is 2/3 to 3/4 complete. The topical agent applied to root surface before reimplantation to inhibit replacement resorption is, I told this yesterday, right? Yes, at least alendronate. Acetic acid we do not use only. What we use is citric acid, and that is also for root conditioning. Do you remember? And alendronate and emdogaine were there. What was the action? It inhibits the osteoclastic activity, so it will inhibit replacement resorption. It is a third generation bisphosphonate, alendronate. Okay. So when you apply it to the root surface before reimplantation, it will inhibit replacement resorption. It will make the root surface resistant to resorption. You remember, right? Citric acid, stannous fluoride, and last one, doxycycline. You want me to explain again, or you have written it down, right? Which of the following is indicated for fracture involving pulp exposure that occurred 20 minutes back? So now the fracture is involving pulp. So it is Ellis class 3. It has occurred 20 minutes back with the permanent incisor which has open apex. So what you will do is, formocrosol pulpotomy is out of question. Calcium hydroxide pulpotomy you can do, but the patient has reported in just 20 minutes. So that is also not necessary. Apexification is definitely not necessary. So the answer will be pulp capping. What material will you use? Or MTM. The most frequently fractured area in pediatric patients is nasal. They are more prone to midface fractures. Maximum period of fixation in condylar fracture in a 10-year-old child is 7 to 10 days. What will happen if you immobilize it for more than 7 to 10 days? Ankylosis. And for those 7 to 10 days also, you have to give active movement to the TMJ. You have to move it actively in between so that the ankylosis does not occur. And in some fractures, first you have to see whether the occlusion is completely deranged or the occlusion is proper and the fracture is not highly displaced. If the occlusion is proper, the fracture is not highly displaced, then sometimes in children immobilization is not at all necessary. What you do is advise soft diet and the fracture will heal. But if the fracture is displaced, the occlusion is deranged, then you give intermaxillary fixation and you immobilize the joint, but only for 7 to 10 days and with active movements in between so that ankylosis does not occur. The most protected area in children is midface, which is the drug used to reduce the duration of soft tissue anesthesia after an endodontic procedure. Phentolamine mesylate. This is called as LA reversal drug. So, but it cannot be given in children less than 6 years of age. But in adults or in adolescent children, sometimes numbness is very uncomfortable, or in mentally retarded patients or medically compromised patients, the numbness is very hard to tolerate for them. So after the procedure is done, you can just give phentolamine mesylate to the patient which will completely reverse the action of